This 13-year-old female patient was referred to me for endodontic treatment of tooth number 8. This tooth was traumatized a few years back, and the patient was taken to her dentist, and the dentist had used composite to restore the broken piece. And a few weeks ago, patient started to have pain, and she noticed this. Labial paralysis. That's the tooth. Right there, as you can see. So patient was taken to her dentist, and her dentist had taken a radiograph of the tooth and told mom and the patient that her tooth was abscessed, and because of patient's dental anxiety, she was referred to us for evaluation and IV sedation to go ahead and do the RCT on this tooth. As you can see, wide open apex. Wide open apex. Huge periapical relucency here. So I discussed options with mother. Let her know that we would like to go ahead and do non-surgical endodontic treatment first, with the possibility of later on having to do an apico, and explain everything to mother. What's an RCT, what's an apico, what I wanted to do during the RCT to go ahead and close that open apex using MTA, and using MTA is beneficial in situations like this, of course, because MTA can give you a good apical seal when the apical diameter is this large, and also just in case in the future we need to do an apico, then we don't need a retrofill. We already have MTA here, so all we need to do is go in and remove this mass, this cystic lesion, and cut a few millimeters of the apical part of the root and put everything back together, stitch her up, and she's good to go. So mother said she completely understood the treatment plan and agreed. So today she came in with her mom, and we went ahead and IV sedated her, and take a look. One thing that happened was, of course, as soon as I did my endo access, I got perianal discharge. I have a microsuction, a surgical microsuction that I inserted to a few millimeters, 2 or 3 millimeters beyond the working length here. My working length was 21 millimeters beyond the working length, and I was able to suction out a lot of this discharge, perianal discharge. I checked to see if there was any more oozing, any more discharge, by using sterile paper points taken to working length, and every single one of them came out, and they were all dry. So went ahead and placed my MTA plug. Placing an MTA plug in a tooth, the apical diameter here was 1.2 millimeters wide. 1.2 millimeters, that's huge. So placing an MTA, if you haven't placed an MTA in cases such as this one, you will definitely extrude, because there's no apical stop, there's nothing here. So you put the MTA in, and it gets extruded out. So it requires a lot of finesse and knowledge and experience, how to place an MTA without a little bit of it could get extruded, but you just need to know how to place the MTA or MTA here, so you don't end up filling this whole lesion with MTA. You just keep putting MTA in, gram after gram after gram of MTA, and you're like, why is it not filling? And then you take a radiograph and you see that this whole space is like almost filled with MTA. Again, because there's no apical stop. This is mid-up. We took an x-ray mid-up just to make sure that my MTA, there are no gaps in it. So this is my MTA plug. I use white MTA. White MTA doesn't stain the anterior teeth, so I use white MTA. And as you can see, my MTA plug is perfect to length. And so next we went ahead and obturated the rest of the canal with gutta percha and sealer, but this is all MTA.